So next, I'm going to bring up Dr. Lubin-Johnson, who's going to share a little bit more from a public health perspective and kind of talking from upstream factors that impact some of the disparities that we see in kidney disease. So Dr. Lubin-Johnson has been an advocate of quality healthcare for all and is the 119th president of the National Medical Association. She is the third president and first woman to have served as president, Speaker of the House of Delegates, and chair of the Board of Trustees. A board-certified general internist, Dr. Lubin-Johnson was in private practice for 29 years and currently is a clinical consultant for healthcare entities and medical officer of the day for a residential mental health facility. Dr. Lubin-Johnson is a past chair of the Women's Physician Section and the Minority Affairs Section of the American Medical Association, and she's a delegate from the Illinois State Medical Society to the AMA House of Delegates and represents the same organization on the Illinois Kidney Disease Prevention and Education Task Force. She was also recently elected to fellowship in the Institute of Medicine, Chicago. So I'm going to let Dr. Lubin-Johnson come on up and share a little bit about some of these upstream factors, and I'll go ahead and share your slides as well.
Thank you very much, Eunice, and good evening, everyone. Thank you for being present. To Jesse, thank you so much for your presentation from a patient perspective. I really appreciate hearing your story. It was truly very valuable and inspirational. So I'm going to talk to you all tonight about understanding structural factors that drive racial inequities in kidney health outcomes. So just a few statistics, 37 million Americans are affected by kidney disease. 1 in 7 adults are at risk of developing kidney disease, and 9 in 10 adults who have kidney disease don't know that they have it. Pretty daunting statistics. The data, more than 100,000 Americans have end-stage kidney disease, meaning they're on dialysis or should be. The cost burden for this is over $125 billion annually for Medicare alone. CKD compromises 14% of the Medicare population, but this expense is 25% of expenditures. And I told you before, 90% don't know they have it, it's undiagnosed. And so that means only 10% know they have it. Next slide. So what do we mean by health equity? I'm sure that many of you have seen, this drawing before that demonstrates the difference between equality and equity. And so equality is everyone having the same thing, but not necessarily having access to the same thing. Equity is having the access to what you need. And so that means we got to remove obstacles to health, such as poverty, discrimination. We've got to address some of those social drivers that we talked about earlier this evening, like, food and safe environment, transportation, housing, good jobs, education, etc. Next slide. So when it comes to community of color, although African Americans are 13% of the population, 50% are at a higher risk of chronic kidney disease, 3.5 times more likely of progression from chronic kidney disease to end-stage renal disease. And we account for 30% of those on dialysis with end-stage renal disease, in spite of only being 13% of the population. Why? Because more African Americans have diabetes, have hypertension, and because we have hypertension at an earlier age. We have hypertension that is also more severe. And of course, family history, which we know occurs with both diabetes and hypertension, and genetics, as we're talking about today being AMKD Day. Next slide. So another part in terms of the structural factors that are challenges are the number of nephrologists. So as Jesse said, I hope all of you are becoming a nephrologist. Because when you look at the numbers of nephrologists per the stage of kidney disease, it's really, there are more people who have a lower stage kidney disease, but that means there are fewer nephrologists to take care of them. And that's really when you want the attention paid. Jesse talked about not knowing he had chronic kidney disease until he was end stage. And really, anyone a woman with a creatinine over 1.5 or a man with a creatinine over 2 should get an ultrasound by their primary care physician, a urine test to make sure they don't have protein in their urine, and a referral to a nephrologist after those things are done. Next slide. So more disparities. The top, hopefully you all have seen Joe Beville's TikTok about the GFR, and unfortunately, this disparity in terms of GFR didn't go away until like a couple of years ago, where the thought was that Blacks had naturally a higher GFR, which unfortunately caused us to get the care we needed when needed, meaning it blocked us from getting transplants in particular because of the misnomer and misreading of what GFR meant for us. Next slide. Resistant hypertension. I alluded to this earlier a bit when talking about hypertension, and for African Americans, it being more severe at an earlier age. My dad was 24 when he was diagnosed with hypertension. 24. And he found out he had it because in the 60s, you had to go have a physical exam to get a mortgage for a house. So when my parents went to buy this home that I am sitting in right now, because I've inherited it, he went and had his physical and he found out he had hypertension. Fortunately, his hypertension did not progress much from that point, in spite of him smoking for over 30 years. We were lucky. But often, you start at that early age, it progresses. And so resistant hypertension, patients need at least 3 different hypertensive classes of meds to control their hypertension. I can remember having 2 patients when I was in practice that needed 4 or 5 medications to control their blood pressure. If you go to the next slide, I'll tell you about one of them. So besides the prevalence of it being more, and half of those who are on dialysis, you go to the next slide. This is half of patients will become non-adherent to their medications within 1 year initiating therapy. So one of those 2 patients, I had him fine-tuned. 4 medications, different classes, fine-tuned. He goes to the barbershop, listens to the fellas talking in the barbershop, stops his meds, and in 2 weeks, he has a major stroke. In the hospital, on rehab for 4 weeks. Okay? So it really does happen. That is a very true story. I'll make it even truer. My dad ran out of his meds in, late 90s. I didn't know. I had a closet full of his medication in my office. He didn't know. He didn't tell my mom. He didn't tell me. He had a stroke. It was in the hospital for 4 weeks, on rehab for 4 weeks. So, of course, it was longer than a year, but unfortunately, that's what happened with him. So this really does occur. And as you all go through your training, and you're interacting with patients, really make sure that they're taking their meds. Don't go, sometimes, unfortunately, physicians will look at a elevated blood pressure and not inquire about taking meds and just add something or increase a dose without really looking at it. I can tell you, one of the best things about having electronic health records would be to allow me to look at someone's refill history of their meds. So I could sit down with them and say, hey, you haven't had this medication refill for 6 months. You can't be taking it every day because you only got a 3-month supply. So if you have pills left right now, that means you haven't been taking your medication. Okay. And so that is a big benefit of EHR. We can know now whether patients are telling us the truth or not, whether they are, and then talk to them about why. Is it they forget? Is it they need, you got to kind of help them out with somewhere to put their meds, so they're taking them? Are they having a side effect and really not being verbal about it? Talk to them and ask them, because that's one thing that's going to keep them from getting the chronic kidney disease. I had another patient who actually, I think I was taking care of his wife already. They went on vacation, wasn't taking care of him, but on vacation, Martha's Vineyard, he's not feeling well. And he just thinks he's got the flu or something. They end up going to the emergency room. He's in kidney failure. He had to be flown off the island to Boston to get started on dialysis, and then got transferred back here to Chicago, where he resumed dialysis and treated. He had hypertension. He wasn't compliant with seeing a physician, taking meds, or anything, you know. So he ended up getting a transplant. I think it was a cousin, but unfortunately, I heard from his wife, because he stopped seeing me. He was seeing, the nephrologist and the transplant team, that unfortunately he stopped doing what he needed to do once he got the transplant, which is really unfortunate. Next slide. So these are stressors that can cause ApoL1 to become to activate an infection like HIV, an autoimmune disease like lupus, sickle cell, because the cells are blocking, causing ischemia in the circulation, rejection of a kidney, and I said before, inflammatory states, and of course stress, racism, because we are altering DNA because of that stressor, but also elevating the blood pressure. Next slide. All right, so this last slide shows the difference between chronic kidney disease progression in Blacks and whites. And it kind of, it looks like there's some questions you can see, like, why do we have this? Is it related to these social drivers? Is it biology? Is it genetics? What is it? But we know that there are definitely differences. And we also know, as was stated before, with having this gene, you get worse outcomes. Part of it is because patients get treated for steroids before genetic testing, and it doesn't work. Whereas if they had genetic testing at the time of diagnosis, okay, we got to do something else. Steroids aren't going to work. So why even be bothered? Why put somebody through the side effects of steroids, and they're not going to work? So I think this is my last slide. I'd be happy to take some questions. I'll tell you what, we'll proceed on so we can get done and then take the questions at the end. Thank you.
Perfect. That sounds great. Thank you so much for your presentation and talking through
You're
some of
welcome.
the upstream factors. That was wonderful.
Thank you.